Well, hello everyone. Thank you for joining us this evening. My name is Tim Cole. I'm the Clinical Affairs Manager for Heidelberg Engineering. And joining me this evening is Mark Holloway. Mark is an optometrist and owner of Thomas and Holloway Optometrists in Dronfield. And we're also joined by Emily Melbourne as well. So Emily is helping facilitate this session this evening, and she's head of the Heidelberg Academy in the UK. And for the next hour, we're going to be discussing how OCT fits into the investigation of glaucoma. And we're going to talk about the risk factors associated with glaucoma and really explain the story of glaucoma and how it fits in with diagnostics. But specifically, the evening was, this session was titled Managing with the Glaucoma Toolkit. And this is a range of scan options and parameters that we deploy with the OCT at Heidelberg. So here are the learning objectives for this next hour, which you'll all get 1 point for, one interactive CET point. So for optometrists, the learning objectives are to understand and how to interpret images we take with the OCT scan, and when these may be indicative of a glaucomatous change, and also to be able to develop a structured approach to OCT scanning and integrate this into a management plan. And that's really the core of the glaucoma toolkit. And for dispensing optometrists, we're hopefully going to cover an understanding of the symptoms of glaucoma and how a patient perceives their disease, understanding of glaucoma, how it will progress if left untreated, and the implications for the patient's vision. So that's more going to be discussed in Mark's part of this evening's session. I'm going to introduce you to the toolkit, to the OCT scan parameters, and as I say, Mark will then take over for the second half. He's going to go through with some of his patients and how he also deploys the toolkit. So I'm going to start really with talking about what glaucoma is. Well, glaucoma is characterized as a slow progressive optic neuropathy. And there's really 5 main types of glaucoma that we investigate. We have open angle glaucoma, the most common, closed angle glaucoma, secondary glaucoma to another disease, or maybe to surgery, normal tension glaucoma, and congenital glaucoma. And the interesting thing about glaucoma is over the years, the theory behind what it is has changed, because for many years it was described as just simply high eye pressure, but now we've moved on from that level of thinking to use glaucoma to describe a group of different conditions that affect the eye, rather than just simply high eye pressure. So when it comes to OCT imaging, as you can see, we've got our whole eye image. That's a montage of a few OCTs put together. The OCT can be very helpful, particularly with open angle and closed angle glaucoma. So here's an anterior segment OCT taken with the anterior on, and here's that an eye with a closed angle. So again, for anterior and posterior, OCT is very, very useful. So really, the OCT toolkit describes how OCT can help, because the great thing about OCT is it provides detailed information about the anatomical structure of the eye, and crucially an objective measurement of progressive change. So not a subjective guess on the shape of an optic nerve, it's an objective defined measurement, which gives you subjective, complements the subjective information with qualitative and quantitative results. Now, what we do with the spectralis is we measure 4 different areas. We measure the neuroretinal rim thickness. Now, in this evening's session, we don't really have time to include that from the toolkit. So we're going to focus on 3 of the 4 things we measure, which are the retinal nerve fiber layer, which of course we do with the circumpapillary RNFL scan, which is that circle scan that's very common with OCT machines when we're looking for glaucoma. We also measure the ganglion cell layer, with a macular scan, which I'll explain in a moment. But with all of these measurements and parameters, the key with OCT is tracking the progression of this disease, because of course glaucoma is a slow-moving optic neuropathy, which naturally does lend itself very well to OCT. So what are the main risk factors that affect the eye with glaucoma? Well, of course, the main one is high eye pressure. This is, of course, still really the core of all treatment for glaucoma, is to try and adjust that pressure to relieve the tension damaging the nerve fiber. But where else do we concerned when we're trying to pick this disease up? Well, of course, fields are a huge part of understanding glaucoma. Family history plays an extremely important part of glaucoma, because, of course, it is often an inherited disease. Ethnicity plays a big part, because with different ethnicities, again, we have different higher levels of occurrences of glaucoma in different ethnicities, but crucially age. And I think this is actually very important in primary eye care, because it's been proven that 10% of patients over 75 years old have glaucoma. So that means really in any primary eye care setting, 1 in 10 of the patients that walk in off the street into your practice probably has glaucoma. So that's an incredibly important risk factor associated with this disease. Eye shape also plays a big part, and also can sometimes make the diagnosis of glaucoma very challenging, with very unusual shaped eyes, and also likewise with the thickness of the retina, because the thinner that retina is, the more difficult it is to quantify and measure structures like the retinal nerve fiber layer and the ganglion cell layer. So what are our traditional glaucoma investigation techniques? Well, the obvious one is, of course, photographic documentation, which of course backs up our clinical exam. And again, this is where most clinicians have been trained to look for glaucoma at photographs. Also, red-free imaging can be very useful. It's a very good way, using red-free photographs, to look at the general area of the nerve fiber layer across the surface of the retina to see if there's a loss of reflectivity. But crucially, it's the assessment of the cut-to-dis ratio, which I'm sure all of you are very familiar with. And really, that's the main part of a clinical investigation when we're looking at the optic nerve and assessing it for glaucomatous damage. But of course, the subjective, the patient's perception of their own vision is absolutely crucial. And that's why visual fields are an absolutely essential part of glaucoma investigation. But on top of these, we also have everything else to consider: the visual acuity, the history of the patient, refraction, eye pressures, corneal thickness for the corrected eye pressures. And I've underlined clinical examination there, because of course this is an absolute must for any sort of retinal evaluation, but also crucially with glaucoma, to do that manual clinical evaluation to look into the eye. And OCT really is a complementary investigation to all these other techniques, and which is why we call glaucoma a multifactorial diagnosis. You can't normally just take one of these values and assume glaucoma. We need to use a multitude of these to build up the story. So when it comes to the story of glaucoma, the good thing about glaucoma, the favor it gives us, is that there's a distinctive pattern with this disease, with this optic nerve neuropathy. And I say optic nerve neuropathy because really that's the beginning of our assessment, isn't it? It's looking at the optic nerve head itself, looking for signs of excavation and damage to those axons which are traveling back to the brain. Another area where we can look for patterns of change are, of course, the arcading radial parts of the nerve fiber layer as they head around the retina and feed into the macula. And of course, it's these axons which feed into the macula that give us another area of assessment, which is, of course, the ganglion cell layer. Now, the pattern of glaucoma can generally be picked up with one of these changes in these structures. But what's crucial about this disease is the pathway of it, because really the end of this disease is often found with the papilla macular bundle. So this is often the last part of the nerve fiber layer to die off as this disease goes ahead and damages the eye. Now, another part of the glaucoma pattern, which is very common, is the simple fact that glaucoma tends to respect the horizontal midline. So what that means is we see changes in these structures that happen on the superior or the inferior hemisphere. And often if that's the opposite way around, with a respecting of the vertical midline, that's actually a sign of a different type of optic neuropathy that isn't glaucoma. So as I say, when it comes to OCT, it lends itself very well to investigating and building up this story. And as I said before, we of course start with the optic nerve. This measurement we make of the neuroretinal rim is actually called the minimum rim width with our system. And that's a measurement taken from the opening of Bruch's membrane to the contour of the inner limiting membrane. We then measure the radiating nerve fiber layer with different sized circles. And again, this is the very commonly used circumpapillary RNFL scan, which we're going to be talking about this evening. And as we travel across the retina, that's where we start to look at the retinal thickness. And also we select out the nerve fiber layer from that structure and indeed the ganglion cell layer itself. And what's new to our technology over the past year really is we've released now normative data for both the macular RNFL and of course the ganglion cell layer RNFL. And I'll come to normative data in a moment. The most common pattern, as I mentioned, is of course the circle scan. Now the circle scan is great. It's a circumpapillary OCT line that goes all the way around the optic nerve and gives us this B scan with and allows us to segment the nerve fiber layer all the way around the optic nerve head. And this is what's commonly measured against the normative database. Now, with our system, you can see in the bottom left there that we have two sets of graphs showing us the normative data. One is the Ted-Garraway-Heath segments, which you can see in the grid on the left-hand side there. That gives us our values of RNFL against the normative data, which is in green brackets. And on the other side of that, you can see this is a very common thing we see with multiple OCTs, where you have that RNFL profile. So that's the segmented RNFL from the B scan put against the normative database. And here you can see the black line and how that individual thickness shape applies against a comparison to the normative data. So the very controversial part of investigating the RNFL for change is what's classified as normal loss and what's classified as significant. And really the jury's still out on this in many ways, because it depends what specialists you speak to. But the general rule of thumb is that it's agreed that around 1 micron of loss is to be expected from a global RNFL point of view. And from the Ted-Garraway-Heath grid, that's that G in the middle. That's the global amount of RNFL. And everyone starts out with around about 100 microns of this structure. So 1 micron a year is generally agreed to be natural. What's seen as significant or an unnatural change can be between 2 to 4 microns of change in nerve fiber layer. But of course, that's part of the story we're trying to build up. So it's not always the single one thing that you can refer a patient from. So when it comes to looking for change, that's really where OCT plays an extremely important role in assessing for glaucoma. And when it comes to progression analysis, that follow-up scan is what's absolutely essential with OCT imaging. And a good way to look for that repeatability is to actually look at our B scans next to each other. And we can do things like aligning the blood vessels. Now, by doing something like this, what we're actually confirming is that there was no head tilt between these two scans, because even if that optic nerve rotates slightly, that can change that profile. of the RNFL. So it's absolutely crucial that whatever OCT you do use to assess for glaucoma, it has very good repeatability. Otherwise, you're going to get false results and it just won't be as sensitive. So here you can see an example of a case when someone deviates from normative data. And you can see I've left a green line on the screen there. That's picking the segmentation of the RNFL profile and how that links to the dip in the normative data. And you can see there's a grey line in the background. That would have been this patient's baseline. And then several years later, this is the subsequent pinching of that nerve fibre layer. And again, detecting this really does come down to sensitivity. So I want to bring to your attention this B scan here. And what I'm going to do is I'm just going to animate the two visits. So these are 8 years apart, these two scans. And it really shows you the thinning of the nerve fibre layer and where we need to look for this structural change. You'll notice that it's the structure surrounding the blood vessels there that's really changing as we go through time. So looking at this data as a graphical form is absolutely essential and very useful to looking for changes in progression, but we also need to be cautious in other areas. What you can see here, and this is actually the same case, is over time, this patient's global RNFL thinning, but not quite enough to push it down into the red. Now, the reason why we're seeing that is from a global perspective. As I mentioned before, the average measurement from all the way around that circumpapillary scan, the change isn't that significant. But if we choose a sector of that grid there, which we've done here with that temporal inferior choice on the progression analysis, you can actually see there's a much more dramatic slant in the progression and the thinning of the structure. So again, when it comes to using OCT in progression, it's absolutely critical that you look in specific areas. So when it comes to the macula, what do? Well, we take a 61 slice high resolution OCT across the surface of the retina. And what we do is we stitch that information together to produce thickness maps of the RNFL, but crucially, we can individually segment the ganglion cell layer. So a normal ganglion cell layer looks like the image on the left. Here you can see this red thick donut of structure surrounding the fovea, and it's very red and hot. That denotes thickness, and it even has some white snow across the top. And you can see on the scale down the side of that image how that equates in microns. So the white there is 17 above microns. So that's the thickness of the peak of the top of the ganglion cell. Now on the right, you can actually see a damaged ganglion cell from glaucoma. And what's happened here is the damage to the nerve axon has actually taken a bite out of this structure. So here you can see a little piece missing. It is common to see a small indentation on the temporal side anyway, because that's, of course, the architecture of the retina and the temporal raphe of the retinal fibre layer. But it's very clear when you can see a piece missing from the ganglion cell sometimes with glaucoma. So if we follow this damaged ganglion cell further, you can see the other eye in the same patient here. They're much further down in the disease process. As I mentioned before, they're at the end stage of the disease where it's leaving the eye with the papilla macular bundle in the left, but on the right eye, the glaucoma damage hasn't got as far as the left yet. So again, measuring the symmetry between the two eyes is also crucial, as well as the hemisphere analysis. So we now have a new report available, and this is sometimes known as a controversial report. But if you do Google and YouTube Donald Hood, he's got some really great lectures out there. And Donald Hood is a professor who's based in the US, who spent many years now comparing OCT thickness information to the visual field results. And this has resulted in the Hood report, which we can produce, as well as a few other manufacturers now, I believe. Now, just to, for the sake of time, I'll just quickly describe the Hood report to you. You, of course, have the normative data down the left-hand side of the screen there. But what I really want to draw your attention to is the thickness of the RNFL around the macula on this central panel and the thickness of the ganglion cell layer. Now, what the HUD report does is it actually flips those thickness maps the other way around and then puts a simulated visual field plot over the top of that thickness information. Now, what we do is we also include our normative data. And what this is actually telling you is the dots on at the top there, 24-2 perimetry test, where they would likely be missed by missing structure underneath. And at the bottom of that 24-2, there's a 10-2 simulation. So again, that would tell you the likely points that would be missed on a visual field test. Now, again, I say controversial because at this point in time, does the HUD report completely replace visual fields? Absolutely not. In many ways, it's just an extremely useful complementary report to add to the visual field test. But again, it's a very good alternative if you've got a patient who for whatever reason, is not very good at doing visual field tests or wasn't able to do them. So OCT, as great as it is, isn't always perfect, like everything else. We often face confounding factors, and really, when it comes to using it as a tool for analysing glaucoma, the key really is understanding what these confounding factors are. And one of the main ones we need to be aware of is other pathologies on the retina. Of course, they will affect what the algorithm is doing, is trying to measure the retinal nerve fibre layer. And as you can see in this example here, we have a B scan of what should be the profile of the inner limited membrane, but actually what it's doing there is it's jumping up and drawing around this epiretinal membrane on the surface of this retina. And the effect that gives to the thickness information is it creates this false horizontal line. So whenever you see any structures like that, straight lines in otherwise circular segmented structures, you should always watch out for those. It can be a sign of a segmentation issue. But as Mark's going to describe later on, and how, as we always try and emphasize, always checking segmentation as part of the process before you make any decisions on OCT information is absolutely crucial. So thank you very much. I'm going to pass on to Mark now, and I'll join you at the end for a little bit of Q&A.
Right, good evening all. Thanks for that introduction there, Tim. My name is Mark Holloway. I'm an independent optometrist. I came to optometry as a second career, having spent sort of 10 years in an account management, I guess, project management type role. Took over the family business about 8 years ago, and we introduced OCT at Dronfield in June, July of 2014. What I'm going to present to you this afternoon is what I do when I'm looking at a patient who has a family history of glaucoma, or who we suspect may have glaucoma, or one of the factors that we're going to be discussing is slightly non-typical. It's not designed to be exhaustive for every type of glaucoma. I'm not going to claim to be a leading authority on glaucoma. It's designed purely to explain how I integrate OCT into my decision making within the practice. So what we're going to do is cover a brief review of sort of glaucoma within a primary care environment, or at least my take on that. And then I'm going to cover 3 cases using that as a workup, focusing obviously on how OCT has helped to make a decision. And then I'll share with you at the end of each of the cases what I know about the patient. The patients have all consented for me to use the data and are happy for me to share where they are in their sort of glaucoma journey, if that's the right word to use. So in terms of glaucoma assessments, as Tim's already said, glaucoma is very much a multifactorial condition, and therefore it needs lots and lots of different tests and analytics and things to be looked at in order to make a sensible referral. And remember, at that point, we're only making a referral. We're not even making a diagnosis. So let's just run through those. As Tim's already said, family history is one that we generally tend to ask about, particularly risks with mum and dad, but more importantly, siblings. And siblings are the ones that carry the greatest risk. If you've got a brother or sister with glaucoma, my understanding is you're about 10 times more likely to have the condition yourself than if you didn't have a brother or sister with glaucoma. Ethnicity, age, Tim's already covered the over 75 point. Prescription is also very important. Glaucoma is more common in myopes, and it's a dose-dependent relationship. So basically, the higher the myopia, the higher the chance of glaucoma. Also, you've got symptoms. So, you know, your classic halos, round lights, pain, red eye, things like that. But generally speaking, they're going to be your angle closure type glaucomas, which you can diagnose probably without OCT. What we're going to focus on here is the lion's share of glaucoma by volume, which is the normal tension primary open angle type glaucomas. Okay. When I did my professor in glaucoma down in London, one of the things that they were quite keen on was asking some additional questions, particularly if you have suspicions around glaucoma. And those additional questions relate to normal tension glaucoma, and they are that if the patient has a history or has Raynaud's, however you say it, which is basically peripheral sort of, if you like, coldness, fingers and toes, anemia, a history of blood loss, transfusion, hypotension, or migraine, then they are also at elevated risk of having and developing glaucoma. We also obviously need to look at the optic nerve head. Tim's already said that looking at the optic nerve head, hopefully through Volk, directly without the use of technology, if you like, is extremely important still. Visual fields remain incredibly important. I just wish more patients could do them better than they sometimes do. IOPs, angle assessment, Van Herrick gonio, probably most of us in a primary care environment are going to be using Van Herrick, although the more I talk to people, the more people are starting to experiment a little bit with gonio. And then obviously we've got OCT, and as Tim said, the three key things are the analysis of the retinal nerve fiber layer around the optic nerve head, the overall retinal thickness, and then stripping out the GCL, the ganglion cell complex, ganglion cell layer within that. You can also look for other factors, which is you're probably going to do at the point that you're looking at the optic nerve. So you can look for things like disc hemorrhages, Drans hemorrhages, pseudo-exfoliation, pigment dispersion syndromes, etc., as well as new vessels if you've got a proliferative diabetic potentially, who may have a sort of vessels growing into the angle. But they are, certainly in my experience, much less common than the primary open angle normal tension or high tension glaucomas. Other considerations that I thought were important to point out, and as I said, this is just purely my take, is that you must make sure that you're aware of local protocols and pathways. So make sure that you're comfortable with what you're doing in the clinical commissioning group area that you're working within, be comfortable with them, but also be aware of the limitations. So for example, in North Derbyshire, where my practice is based, we do have a glaucoma referral refinement pathway, but that pathway is really only applicable to suspicious fields or elevated IOPs. If you have suspect optic nerve heads, RNFLs, OCT findings, they still need to be referred via standard pathways via a GOS 18 or whatever your local pathway is. The other things to point out are always practice within your limitations. I'm not a glaucoma specialist. I know a little bit about glaucoma because it's very common within my patient demographic. So I wanted to learn a little bit more about it than perhaps is average, but always practice within your limitations. I can't prescribe drugs. I'm never going to tell a patient to up their drugs, stop taking their drugs, etc. And the other thing is make sure that you've got comprehensive records. Record even for your OCTs and your visual fields and things like that. Make sure that you record your findings, the advice that you've given the patient, and the next steps. And the other thing that I tend to do is make sure that I've recorded that the patient is happy with the decision that we've made together, because I think that's quite important as well. So moving on to sort of OCT, as that's really the focus of this evening, a standard assessment for somebody with glaucoma is going to involve doing three particular things. One is a horizontal vertical high resolution scan through the fovea. The second is the 61 line posterior pole plot, which can then be segmented and from which you can strip out. You can not only look at your B scans, but you can strip out overall retinal thickness, ganglion cell thickness, and when you've got change over time. As Tim said, and I really don't think that this can be stressed enough, it's really, really, really important, particularly when you're looking at a baseline reading, that you have a quality baseline scan. Particularly with the Spectralis, because it uses active eye tracking, and all I do is call up a patient on a repeat scan and pull that scan forward and rescan. Any errors in the baseline scan can be followed through into the second patient, and the data, the comparative data, will not be as valid and not be as good quality, and any decisions therefore made on that will not be as good. So make sure that you check your segmentation, make sure you check your foci line position, etc., etc. Just make sure you've got good quality scans and that you've checked all aspects of them. Again, checking for artifacts. You can get blink artifacts, although not commonly with the spectralis, but as Tim said, epiretinal membrane artifacts, things like that. Remember as well that OCT is purely looking really at structure, but the visual field is looking at function, and it's the synergy of those two, form and function, that are of the most use when we're looking at glaucoma. Now, the other thing is, remember that the OCT is not a magic machine. It doesn't give us the answers, but it damn sure helps build up the picture, as we'll see from some of the cases, two in particular, that we're about to discuss. So let's get into the cases. Hopefully, I'm not trying to teach you to suck eggs. I'm sure that for nearly everybody on this webinar, those things are just just a very brief refresher of the things that we already know and are probably doing on a day-to-day basis. So let's look at the first patient SH. What I've tried to do here is give a brief history and symptoms with the findings relevant to the things that I think are most important with glaucoma, okay? And then obviously we're going to drill down into the OCT findings a little bit more. So this patient, SH, is a female, 75 years old. It's a family history of glaucoma with both brother and mother. She's a white Caucasian. She's a low hyperope, low astigmat. There's no normal tension additional risk factors reported. Optic nerve heads are very, very slightly asymmetric, but nothing drastic. Field, she's reporting no abnormalities. Pressures are normal, 20 right and left. Other factors, no obvious disc hemorrhages, pseudo exfoliation, pigment dispersion, etc. when we're looking on a slit lamp assessment. So nothing particularly suspicious and worrying so far. These are the optic nerve heads that we see. Again, there's nothing drastic here. There's possibly a slight asymmetry in the optic nerves, but to me, there's nothing overly drastic there at all. So consistent with what we found from our clinical examination through Volk. So on the surface, things are looking all okay. Next, we drill down into the retinal thickness scans. Now, when we look at the table, the numbers down in the bottom here, the overall numbers of the total thickness of the right retina and the left retina, and then the superior hemisphere and inferior hemispheres, don't look too bad at all. They're fairly symmetrical. However, what we do have is this dark sort of arc just here. Now, this is the first little sort of like ringing bell saying that maybe everything isn't quite as perfect as we perhaps might have first thought. One thing I should say on these ones, talking about artifacts, is that when you are looking at these particular scans, it's quite important to make sure that you check for blood vessels in this location here and this location here, because if you have blood vessels that are emerging in this area here but not there, that's going to throw off the scan, because what this is doing is it's looking at overall retinal thickness and comparing the inferior with the superior points. So this is saying that in this area that's dark here, the retina is measuring quite a bit thinner than in the mirrored part just up there. Now, from looking at this, from seeing this in first hand, but even on these scans, there are no significant blood vessels that would be causing an artifactual error just there. Okay. What we can then do is we can look at the RNFL scans. So in this particular case, what we've got here really is borderline segments and an outside normal limit segment in exactly the wrong places. We know that glaucoma on the retinal nerve fiber scan, circle scan, tends to affect the temporal superior and temporal inferior segments more than others. So the second that you get borderline measurements in these areas here and here, we've got to be, our ears have to prick up a little bit that we potentially could be looking at glaucoma. It could be normal, it could be how the patient is, but there's a problem. There could potentially be a problem here. Now, in this particular one, we've got very much an outside of the normal limits in this left eye. Now, this patient is a long-standing patient. This is one of the more recent scans that she's had with me. What we can actually do in this particular case is we can look at the change over time. So now we're playing the spectralis as trump card. We're looking at change over time. So the active eye tracker is locked onto the optic nerve. We've built up the circle scan. We know that we're scanning the same segment of eye or same structure time after time after time. And now we can look at change. Now, some of this is a little bit difficult. I don't expect you to see all of the numbers, but basically the baseline scan here is from the 14th of April 2015. At that point, this temporal superior, this temporal inferior wedge here was measuring at 94 microns, okay? By the time we get here to July 2019, that has reduced to 79 microns. So over the course of 15, 16, 17, four and a bit years, we've dropped from 94 to 79 microns. Now, I'm not the quickest at mental arithmetic, but that's a big difference to the 1 to 2 micron change that we would expect. So even if we said 2 microns a year, we'd only expect 8 microns loss over 4 years, and we've got significantly more than that. So what we've got here is this progression change, and that's really, really important. We can also then drill down into the ganglion cell layer. So as Tim presented in his introductory slides, we would hope and expect to see a full ring, a full red ring with some white peak over the top. Now in this right eye here, that's not looking too bad at all. We don't have probably quite a full bullseye appearance, but what we definitely can see between these two images is that we've definitely got nipping of the GCL in this area just here, and this area down here is a little bit thinner than in the counterpart eye. So we've got slight what we would call snail shelling, and it's not what I would call a full bullseye ring. Again, going back to the basics of just looking at an infrared image, if you've got a nice healthy retinal nerve fiber layer on an infrared image, the black and white scan on the spectralis, we'd expect to see like a sheen and a shimmer across the surface of the retina. So this very light grey appearance. What we can see here is a defect, is a change in the reflectivity. The retinal nerve fiber layer, because it's thinned, has lost some of its reflectivity, and it's very difficult to see on this image, but you can actually see that that's formed into a slight gully. So this position in the temporal inferior optic nerve head is consistent with the positioning of the GCL just here, and it's consistent with the change that we would expect with this thinning and hemisphere asymmetry here. So if we then look back at the patient as an overall, what I've tried to do here is go back to the history and symptoms and flag everything that now becomes suspicious in red. So we've got somebody 75 years old, so they're in that sort of 10% over that age or around that age are having glaucoma. She's got family history of glaucoma, and it's quite a strong family history, particularly with having a sibling. Yes, there's some asymmetry in the optic nerve, nothing drastic when you look in with a volt. But what the OCT has done here is it's confirmed that we've got, we've definitely got suspect retinal thickness asymmetry. We've also got suspect ganglion cell layer appearance and asymmetry between the two eyes. But most importantly, we've got evidence of progression. We've got evidence of a progressive notch in that temporal inferior segment within the left eye. Now, this lady was actually referred into the hospital on the basis of the progressive notch. She's now seeing the hospital around about every 6 months, or at least she was before COVID kicked off, and she's using Lumigan daily. Now, if we take away number 11 there, would this patient have been referred into the hospital without having an OCT to give me that progressive notch? I don't know. Not with pressures of 20 and full fields, probably. It would have probably had to have progressed to a more developed stage, and we wouldn't have been referring and hopefully slowing down the progression of the disease to a manageable level in her lifetime. So let's move on to the second case study. This is patient LJ. So this is a gentleman, 80 years old, no family history of glaucoma, white Caucasian, low hyperope, no normal tension risk factors reported. Optic nerve heads are asymmetric. He's got a right of 0.5, left of 0.2, 0.5, 0.4. Visual field, there's a right defect. IOP is 22 and 19. So within the 24 millimeters of mercury, but there is a slight asymmetry there. No other factors, no obvious disc hemorrhages, etc., etc. So let's have a look through the OCT on this one. These are the visual fields, by the way. I just started off with FDT fields. So we do have a slight something going on in this superior area, but it's not drastic. And in fact, between the two, there's only one repeatable point missed. And you know, often if it weren't for some of the other factors, you may just bring this patient back maybe in 6 months, or refer into a glaucoma referral refinement pathway if you have one available in your practice. Optic nerves. Now, the infrared images here are basically confirming what we said from the clinical assessment. The right optic nerve head there is definitely more cupped, more deeper, and is more suspicious than the left optic nerve head. When we come on to the RNFL analysis, the overall retinal thickness analysis, what we can see here is lots of black in this right eye. So what this is saying is that the right eye is significantly thinner than the left, and that the inferior part of the retina is thin compared to the superior. But what we know about glaucoma, it's not written in blood, but what we generally know about glaucoma is that it tends to affect one eye more than the other, and one hemisphere within that eye more than the other. And in this case, it's the right eye and the inferior hemisphere that seems to be being most affected by the glaucoma. And you can see that pattern there. Even the overall thickness of the retinal patterns are very asymmetric. This left eye is far thicker and fuller than the right eye. When we look at the RNFL plots, again, we've got temporal inferior suspect wedges, but particularly in that left eye, the temporal inferior and nasal inferior, the whole of that eye is looking pretty suspect now, and outside of normal limits. And again, quite different to the left eye. I don't have any. This gentleman, by the way, is a long-standing patient, but for one reason or another didn't come to see me for about 8 years. He had a bit of a gap between presentations, and that's where probably this change has happened. So this is the first and only scan that I had. When we look at the ganglion cell layer complex, we can see a very, very different story. We're not quite at the papillomacular bundle sparing that Tim showed in his sort of worst case slide on the introduction, but we can again see that we've got a very, very significant asymmetry here. So what have we got? We've got an 80-year-old patient with asymmetric optic nerves, a visual field defect in the right eye, and OCT is basically adding to those factors, confirming that there's retinal thickness asymmetry, RNFL asymmetry, and GCL asymmetry. Now, this gentleman was referred into the hospital. Even without OCT, this is probably one that would have been referred, but all OCT did was sort of sign and seal and deliver the deal, so to speak. It really added the weight to the argument. And the reason that I've chosen this one over the first one is that the way that I tend to think about glaucoma in my practice is that patients fall into one of 4 categories. Category 1 is all findings and history and symptom and clinical evaluations are all perfect. Those patients get ticked off, they come back in 12 or 24 months, whatever their standard recall would be. Patient 2, category 2, is where a patient may have 1 or 2 measurements that my ears are pricked up. I'm not totally happy to sign off, but there's no evidence of significant problem or significant or change. Patient 3 are those where you've got evidence of progression and change, so and enough factors for you to be concerned about glaucoma. And I would probably put the first patient case study into that category. And then you've got these ones, patient category 4, which is the barn doors. There's not very much about this that doesn't suggest glaucoma. So two very different cases, but the OCT in the first one was probably the clinical clincher. Without it, the patient may not have been referred, in this particular case, the patient probably would have been referred, but the OCT adds the weight and the credence to the referral. So coming on to the final case study here. This time we've got another female, 66 years old, so fairly young. She's got a family history of glaucoma with mum, white Caucasian. She's a low hyperope, although in the right eye, the left eye though is balanced. There's quite extensive but quite central corneal scarring, so she's achieving 660 at best, even best corrected. I can't get her any better than that. She's no normal tension glaucoma risk factors. The optic nerves are broadly speaking symmetrical. The fields are no abnormalities, and the IOPs are within a normal range of 14-15. Again, we've got no other clinical factors evident on a slit lamp assessment. So let's have a look at the OCT. So here what we can see is a nice clear infrared image of the right optic nerve. The left is quite blurred, and that's due to the corneal scarring. However, just because the infrared image is a little bit more blurred, the actual OCT segments that we get for this eye, because of the way that OCT, optical coherence tomography, works, the actual OCTB scans are pretty good. It's just the infrared images that become a little bit grainy. But again, looking at those optic nerves, particularly the one in the right eye, there's no sort of major problem here. Then we look at the retinal thickness mapping, and again, what we've got here is this slight asymmetry whereby the right retina here is thinner overall slightly than the left, particularly the superior hemisphere is thinner than the left, but also thinner than the inferior. And when we look at the grayscale, we can see that we've got this quite sort of marked dark area just here, suggesting this superior retina in the right eye is far thinner than the mirrored counterpart underneath, to a clinically significant level. When we look at the RNFL plots, again, if you picture where the problem is up here. And when we look at the RNFL plot, sure enough, the temporal superior segment of this right eye is measuring as being borderline. Now, again, this is a patient who's been coming to see me for a number of years. And over the course of those years, that temporal superior segment has reduced from 129 to 97 microns between 2014 and 2019. So over 5 years, it's decreased by, what's that, give or take 32 microns. So quite a significant drop over that period of time. And you can actually see with the graphical analysis here, this is the baseline scan. And what you can start to see here is the notching in that temporal superior segment getting bigger until the final scan that I did in September of 2019. So way outside the range that we would expect and hope to see in a normal individual based purely on age. Again, ganglion cell complex. On the face of it, don't look too bad. You've got a full red circle there with some white peaks. However, when you look at the appearance, you can see here this almost sort of like step in the GCL here, with the thinning arc coming back from that point back up into the optic nerve head, particularly when you compare it to the inferior. So again, whilst there is a complete ring of red, and you could say, well, it looks like a bullseye, it's not an even bullseye, and we do definitely have some clipping of the ganglion cell layer in that area just there. Now, when we look at the 3D images, these are diagnostic, but patients love looking through these because they can contextualize what they're looking at. Again, what we can see is that where we've got that wedge of reduced RNFL thickness, you can see the reflectivity change on the surface. The RNFL has lost its luster, and we've got that sort of dark arc just here. And again, when we look at it in cross section, you can actually see, when I pull that round into a different angle, the gully that's been formed there, where this notch is in the temporal superior segment of this right eye. So again, if we take away point 11 on this particular summary slide, What we've really got on the face of it was a 66-year-old patient with a family history of glaucoma from mum. Without OCT, we wouldn't have seen some of those other things, or it would have been a lot more difficult. What OCT has given us again is a suspect retinal thickness asymmetry, a suspect GCL, but most importantly, again, a progressive superior temporal notch in that right eye, evidenced both by the GCL reduction, the reduction in the RNFL, and also the change in the structure and form using the infrared images and the 3D scans. Now, this lady was actually originally seen by myself in 2014 up here. She was actually referred in 2016 because I was already getting suspicious of this notching, and so I referred her. The hospital had a look at her, monitored her for a spell, but discharged her because her fields and IOPs were normal and they weren't concerned with regards to the ophthalmoscopy. So she came back into me. She was a little bit nervous about that, particularly given the fact that the left eye is quite poor VA, and the last thing that she wanted was a 660 left eye and a tunneled vision right eye, and that was how she could live a life. She's only 66 years old now, so who knows, this patient might have another 20, 30 plus years ahead of them, and we need to keep that right eye as healthy for as long as we possibly can. So I actually built up the picture a little bit more and sent it to an alternative ophthalmologist. It happened to be a private ophthalmologist in her case. They sent it for a second opinion, if you like, and that's when they had a bit more evidence in terms of the RNFL progressive notch. They diagnosed early normal tension, pre-perimetric normal tension glaucoma, and she's now using Xalatan on a daily basis and is being seen again every 6 months. Again, when we look at the history and symptoms and the workup without the OCT, again, would we have diagnosed the glaucoma in that patient? I'm going to say very unlikely, or at least for me, very unlikely. So there we go. Three sort of very different patients, three different uses of the OCT, but I think the key thing is to use a systematic approach, using the toolkit that's available and thinking about things in a logical manner, and build up the story, build up the picture. Have I got enough evidence right now to refer? Do I need to build up the evidence base a little bit more before I refer? Or is everything absolutely fine and can we just see this patient on a routine basis? So thank you for listening to my section of the presentation. I'll hand back to Tim, and I think we're going to field some questions.
Yeah, thank you for your presentations, Mark and Tim. I've got one for Mark here, I think, initially. So when would it be useful to carry out a 10-2 visual fields? And is there a particular hemisphere asymmetry you would expect it to correlate with?
I'll be honest, I tend not to use a 10-2 field screening protocol. I do the FDT field and use that as a basis to refer into a glaucoma referral refinement protocol, or if the FDT field is fine and the OCT's suspect, then I'll jump straight into a 24-2 on a Humphrey. I tend not to use the other protocol. So sorry, I'm probably not much help there.
No worries. And I've got another question here. Please, could you expand on how to ensure the baseline reference scan is of the highest quality and how you can change which scan is used as the reference scan if needed? So that may be one for Tim.
Yeah, of course. Well, checking you've got the highest quality baseline scan really comes down to looking at the contrast of all the layers of the OCT. Can you see them on the scan? It's pretty, it's as straightforward as that, really. And has the segmentation done a good job? As I mentioned in my intro there, that's the crucial thing before we go anywhere with the assessment, is double checking on that segmentation.
I think practice, and making sure you've got enough time to do it. Whoever's capturing the images needs to make sure that they're well versed in how to capture the images, but then also how to check the scans through. You literally, with the 61 line scan, have to scroll down through each of those 61 lines, make sure the segmentation is correct. Once you've got the overall segmentation from the retinal surface down to Brooks, then what I do is check that, and then I go ahead and segment the scan. I think if you segment the scan before you've checked that, the errors just seem to follow through. So it's just about having a systematic approach to doing things and practicing. You know, some of the earlier scans that I did weren't great, but they've got hopefully a lot better over the years.
I think on top of that as well, I think it's always worth considering the patient's tear film. As we find with other different scan parameters and scan patterns, the tear film, or what I've heard explained in the past, or the third lens of the eye, I think is actually very important, because that can drastically affect the signal quality of an OCT. So if someone has got evaporated tears and you're trying to take an OCT of that eye, it's of course going to impact on the signal to noise ratio, and that will of course carry through to the contrast of the layers and the segmentation of the structures. So I always do this when we're doing our hands-on training. If you do have a patient with meibomian gland dysfunction or just really bad evaporated tears, give them a little drop of Viscotears or Celluvisc or Hypermello, something that's gloopy and sticks to the surface of the eye and gives you that tear film while you're scanning. And that can really mean the difference between a good and a bad scan sometimes.
Yeah, totally.
Yeah, and then they'd asked how you can change which scan is used as the reference scan if needed. So if you're not sure how to do that on your Spectralis and that's what you're using, just drop us a line and we'll be happy to send you some instructions on how to do that. But you certainly can change the reference scan and reset that reference if you need to and you didn't like the first scan. And then we've got another question here. Do you charge patients for those scans, Mark? And if so, what's the cost to them?
Yeah, so yeah, we do charge patients. We charge £35 to do an OCT scan. Just before COVID kicked off, we were planning on increasing that to £39. There's quite a lot of work involved in doing it, in my opinion, in doing the OCT, and it takes a bit of time. If you're going to look through all of those scans, take the time to segment them, put all this picture together, it's not something that can be done in 2 minutes. So yes, we charge £35 to have an OCT scan done. For that, we obviously cover not only the glaucoma side of it, but the macula side of things. I know that some places do charge separately. So if you've got family history of AMD, they'll do like a macula package. If you've family history of glaucoma, you can do glaucoma packages. There are many different ways that you can cut up the OCT cake and charge for it. I'm fairly simple, £35 for a fairly, comprehensive suite of scans. Keep the cost down to encourage uptake, basically.
Yeah, and we've got a follow-up question here from the same person. Do you give them a copy of the scan to take home?
I don't give them a copy to take home because I think some of it doesn't mean a lot to them, and there's such a lot of scans there, it'd be very difficult to do. I do frequently get patients asking me for, that looks good, can I show my husband because, or can I show my partner because you've shown the asymmetry in the asymmetry plot. So you might print 1 or 2 scans out. But generally speaking, I don't as standard give a patient something, but of course I'm happy to share it with them if they want it. You can obviously, if you're referring into primary care or secondary care, but it's not something we can do well. With the Spectralis, you can drop out a file. Is it an EPS file it's called, isn't it? So you can
E2E.
drop out the E2E, sorry. So you can drop out an E2E file and you can send that into a secondary care environment. And I do some scans for a private consultant in Sheffield, and sometimes he will ask for me to send those with patients on a memory stick. And then he can basically plug that into his OCT, his Spectralis at his end, and it looks as if he's captured the scan, but without having to do it. So we don't have to do that often, but, those things are available.
Okay. And another question here for Mark. Can we ask Mark if he uses central corneal thickness as an independent risk factor for normal tension glaucoma, or to more generally correct the IOP to a more representative value?
I don't measure central corneal thickness currently, so yet in my history and symptoms, in terms of the suite of tests that I do, it probably could be considered as a glaring omission. At one point when I was doing my professional certificate down in London, the glaucoma, I was looking at one of the corneal hysteresis machines that is actually the step on from corrected, and it's based on sort of like a second, people probably know it's based on like a second IOP reading, like a rebound reading, which is supposed to be more correct. But no, I don't use central corneal thickness. No, I'm looking at acquiring a piece of equipment that may be able to do that, but I don't currently do it.
Okay, and so what I will say is it is 8:30, so if you do need to get away because you have a life outside of webinars, then you're very welcome to now leave, and you will still get your CET points, so don't worry about that. But if you want to stay on, we will just answer 3-4 more questions that have come through, so you're very welcome to stay with us. So, but don't feel bad about going if you need to go. Okay. So another question for Tim here. Why would you use the large posterior pole scan you showed rather than segmenting the regular macular cube scans and viewing the RNFL and GCL using those?
Yeah, it's a really good question, actually. Well, what you might notice about the posterior pole scan is it's actually on an angle when you look at it. It's tilted, actually, to the profile of the fovea to optic nerve. So it actually takes into account the actual orientation of those axons as they feed into the macula. And most eyes have that slight kind of 7-degree drop down from the optic nerve. So that's why the peephole is slightly rotated to take that into account. The other thing to remember is the posterior pole was actually specifically designed by Heidelberg, actually by the late Gerhard Zinser, as part of the assessment process for glaucoma. So not only is the shape very important for measuring the ganglion cell layer, the inner plexiform, and the RNFL, but actually the amount of segments and the amount of ART, or averaging, as other people might know it, it is applied to each of those single 61 sections of the pattern. So it's actually been specifically invented to do that. And of course, the thing I've mentioned in my intro was the simple fact that we've also now got normative data based on that pattern. So I strongly recommend anyone with a spectralis who maybe has the enhanced glaucoma package or GMPE, I would recommend that you use posterior pole. But even if you don't have the premium edition software, the peephole scan, as I say, was invented and designed for analysis of these upper retina layers. So that's why.
Cool. And there was another one for Tim here about Tim and Mark, actually. What is your opinion about age-related thinning in over 75s and glaucoma? Is it really glaucoma or a similar neuropathy brought about by old age?
Mark, do you want to start on that one?
I think the 2 micron loss is just degradation of nerve fiber layer just due to the aging process. There are people that are far cleverer than me that are looking at using OCT, and Tim will probably pick this up, in order to diagnose things like Alzheimer's and dementias, because some of those conditions, because the RNFL is effectively, and the eye is effectively, an extension of the brain. And so, yes, there are other optic neuropathies that can be picked up through OCT, but apologies if I'm not understanding the question quite right, but the 1 to 2 microns per year loss is based purely just on age-related decline. And if it's outside of that, then it would hint towards a disease process, one of which could be glaucoma.
Yeah, I totally agree with Mark, really. And again, I said it already as well at the beginning, it's a controversial subject because it really depends who you ask, and even can affect your referral success in wherever you are in the country, how into OCT your local glaucoma specialist is. I think the thing to remember again, though, is when it comes to differentiating the optic neuropathies, the studies out there and the data shows that it is all about that respecting of the hemisphere, whether that be the inferior and the superior, like we do with glaucoma, with the horizontal midline, or with that vertical one. And I think even when you're dealing with particularly thin, older retinas, or maybe even very myopic retinas, they're always tricky anyway. The pattern of atrophy is often follows that rule. But I do agree, it's a controversial subject and very tricky, particularly when it comes to long stretched eyes. That's always the tricky one, because with anything, if you stretch it and make it thinner, it's simply harder to measure it. And you always have to remember that all the normative databases aren't designed for unusual shaped eyes. It's a set of parameters, which again, if you're interested in the exact details of that, we can email you the exact normative data information. But I believe there's no one more than, I think it's -2 or +2 on these databases around that. So yeah, when it comes to older, thinner, strange shaped retinas, it's more challenging.
And one for Mark here that's just come through. In the absence of abnormal fields, abnormal IOP and a normal looking disc, if you are concerned about the ganglion cell layer, in your experience, how do consultants in the hospital eye service tend to manage the patient?
I think, as I showed it, I think in case 3, I think it really depends on who picks it up. I think some ophthalmologists seem to pay more credence to OCT findings, but as we discussed in the webinar earlier this afternoon, one of the questions then was related to treatment of glaucoma and the limitations that are put on ophthalmologists by NICE. And you know, certainly even only a couple of years ago, the NICE guidelines didn't really take into account OCT because it's relatively still new, particularly in the volumes that we do primary care are doing them in now. So I really think it depends on the hospital and even the consultant that happens to pick up that referral. Some will be like, no, done a Volk, this looks good, fields are full, pressures are fine, no significant risk factors, go away. Others will pay more credence to that OCT. It seems to be my experience, it's very mixed.
And another question that's come through here, would advanced glaucoma still respect the horizontal midline?
A very good question. So from what I know, the very end stage of the disease is where the story does fall apart somewhat in that sense. It's the sparing and the end of that papilla macular bundle. Now, whether or not that papilla macular bundle still respects the horizontal midline, I actually genuinely don't know. I've not seen a study to suggest that. Mark, I don't know if you've looked at enough patients with remaining PMB. I must be honest, when it gets the end stage of the disease, this is where, again, this is where you've got to say to yourself, how useful is OCT at that stage of the disease? A lot of the time, that's where these specialists still switch to looking at the visual field to just check what remaining vision that patient has. Because when there's nothing left of a structure to quantify anymore, the only thing you can do is start to ask the patient what they can still see. And that's kind of the same with a lot of end stage disease. If there's, you know, for example, the AMD, if it's dried up, there's no fluid, and you're just looking what's left of the retina, you've really got to do microperimetry and general perimetry for glaucoma to assess those things at the end.
And I've just got one more question here for Tim. When would you recommend using that glaucoma hood report?
I mean, as I mentioned, I think it's at this point in time, it's very controversial. When I speak to ophthalmologists at exhibitions, and around the country and around the world, when we go to these international meetings, I get a mixed response when I bring up the hood. Some consultants go, oh yeah, Donald's a good friend of mine. I've watched his YouTubes. He's a brilliant guy. I see where it's going, but it's not there yet. Others say, oh, I don't believe in that at all. And some I've even heard say, well, I think it's brilliant. Why do I need to do fields again? Where I stand on it is I would never dare say it replaces fields, simply because I'm a good friend. I consider myself a friend of David Crabb, and he would kill me if he heard me say that fields are valid. I think it's a very good complementary report, and I think its weight really lies in the patients that are terrible at doing visual fields. And I know, again, that can be a bit of a controversial answer, because you could argue that most patients are bad at fields because fields are tricky. But yeah, I think in the same way OCT is, it's a very useful extra arm of investigation. And if you combine it with normative data, it's even better. So yeah, I wouldn't say at this point in time it replaces anything. It's a very good complement to our toolkit.
Great. So, yes, thank you, Mark Holloway, our guest speaker for tonight, and thank you to my colleague Tim Cole for their excellent presentations, and thank you to our audience and all the nice questions that you asked us. To the 167 of you who have stayed with us to the bitter end, if I could give you an extra CET point, I would. Thank you for sticking with us during this time. So, yeah, thank you very much, and we hope to see you again at the next webinar.
Thank you,
Bye-bye.
everyone. Thanks, Mark.
Thank you. Good night.